So I just want to welcome everyone who's on this webinar to our very first MLD Standards of Care meeting. This is the first of 3 in a series, and it presented by CureMLD. CureMLD is a global patient advocacy collaboration, and we are dedicated to fostering collaboration among our stakeholders. And so we're so excited to kick this off. In session 1, we're going to be covering a lot of different topics. Actually, we're going to be talking about, sorry, my slides are advancing. We're going to be talking about everything from ways that advocates can get involved in advocacy and advocating for different issues that are important to the MLD community. And also we'll be talking about psychological support, as well as getting updates about the state of the research. My name is Erica Barnes, and I am the founder of Chloe's Fight Rare Disease Foundation. I got into this space following the death of my daughter, Chloe, in 2010. And I've been working to advocate ever since. And I'm so excited about this opportunity to collaborate with other families and other organizations that are dedicated to improving care for MLD families. So before I introduce any of the speakers, I just want to let everyone on this call know that we will have a chance at the end of the presentations to do a Q&A. So feel free as we go through these presentations, as you think of questions that you would like to ask the speaker, please put your questions in the Q&A section, not in the chat. So we'll be pulling the questions that we get from the Q&A and not from the chat. I know sometimes on webinars that can be confusing. Also, we are recording this session. So if you know of anyone who couldn't make it today who wants to see this, we will make that recording available. So I want to introduce today's speaker real quick. I think there's a slide for that. If we have a slide with the name of the speakers, not sure. So I'll just, I know they're going to introduce themselves later, but we have Melanie Rumbel. She is with CureMLD. Oh, there we go. Wonderful. Here are the speakers for today. Melanie Rumbel is she is a partner with CureMLD. She'll be presenting on some of the work that CureMLD is doing. Dr. Laura Adang, many of you probably already know. She will be presenting on giving us updates about the state of the research, and she's employed at Children's Hospital of Philadelphia. Then we have Lesa Brackbill. She'll be talking to us a little bit about newborn screening in her community. And then Dr. Al Freedman with Freedman Counseling Associates. He'll be talking to us a little bit about the psychological support for the community. And they will do a more extensive introduction when they do their presentations. So I wanted to just briefly go over the agenda with everyone. So each of our speakers will do a 10-minute presentation on the topics that you see on the screen. After that, we'll have 45 minutes of a moderated discussion with the panel, kind of a conversation among the panelists to kind of interact and engage with the information and the topics that they talked about. And then after that, we'll do 30 minutes of Q&A from you that are listening in the audience, and it'll be a more open discussion. Again, put those questions in the Q&A section, and then we will review those and add those to the discussion. So without further ado, I want to turn it over to Melanie. Melanie, take it away.
Hi, everyone. My name is Melanie, and I'm going to, I think I just accepted. So there we go. My name is Melanie Rumbel, and I started working with CureMLD in July of 2020. So on behalf of CureMLD, I want to say welcome to the conference and thank you for joining. I started working with CureMLD last year, so it's been about 8 months, and I work as the program manager and outreach coordinator for the ambassador program. And I started in the leukodystrophy space when 2 summers ago, I had an internship at the Children's Hospital of Philadelphia This internship was funded by the Calliope Joy Foundation, and I had the privilege of working with Dr. Amy Waldman doing clinical research for Alexander disease, which is another type of rare leukodystrophy. And so today I'll be talking more about our global outreach efforts and how we're consolidating those efforts into our patient contact registry. Oops. There we go. So currently our patient registry is housed in our community survey. And when we started our community survey, we didn't necessarily know what it'd be used for. It was simply a way to keep in contact with people. But it has proved to be this incredibly useful tool. And so today I'll talk more about some of the insights that we've gained from our community survey. So what you're looking at here is a map that represents where all of the MLD individuals in our community survey are located all around the world. And so this map represents 82 different individuals with MLD from 75 different families, because sometimes there are affected siblings, across 18 different countries, the majority of which, as you can see, are in the United States, which I think makes sense since we're based in the US. And so when a family reaches out to us, we do a couple of things. We send them a care package, which has helpful information about leukodystrophy care and medical guides and some gifts for the caregivers, et cetera, et cetera. But probably the most important thing that we do is consult with the families to see what their needs are and what they might be looking for. And a lot of times this means looking at what clinical trials they might be eligible for. So we help families connect to teams that can evaluate the individual for a clinical trial. We also connect them to other leukodystrophy care experts if there aren't any in the region that they're from. And we also, so last year, we also had a family reach out to us from Pakistan that the child was a suspected case of MLD, but they didn't have testing in that region. And so we worked with Dr. David Wanger from Thomas Jefferson University to get these samples extracted in Pakistan, these biological samples, flown to the US and shipped to Philadelphia, where Dr. David Wanger was able to test the samples. And that was no small feat, but he has been doing amazing things in the field of leukodystrophy testing and lysosomal storage disorder testing. And the family ended up testing negative, actually. So the one that we see here, the Pakistani family on this map, is actually a different one. And the last thing that I'll point out on this worldwide map is the country of Ireland. So I'm going to speak more about what we're seeing in Ireland. So on the left here, you see a table which just represents the same data that we saw on the map before. The countries listed out where each of the MLD individuals in our survey lives, and that's key. So we have 4 Irish families that are living in Ireland, but we also have 2 Irish families that are living in other countries and therefore are represented elsewhere in our survey. But that number of Irish families that we see coming to us is actually more like 5 or 6. And this is significant when we look at the size of Ireland, which is what I have here on the right. It's a comparison to the US state of Indiana. That's how big Ireland is, which means that it's really small. And so the small size of Ireland, coupled with how many cases we're seeing come from that region, leads us to wonder if there might be a higher incidence of MLD in the Irish. And so this sort of thought pattern, coupled with thinking about MLD newborn screening, leads us to think about maybe Ireland could be a good place to possibly pilot MLD newborn screening in the EU. And so moving on to what we see within the United States itself, this is a map of our US families spread across all of the 50 states. And there are a couple things to note here. First, we have a family in Alaska that is connected to the Alaska Native Health System. We're also connected to the South Central Foundation up there, also connected to the health system. And this is a really precious connection for us because the Alaska Native population has a much higher incidence of MLD than the rest of the world. In the general population, the incidence of MLD is between 1 in 40,000 to 1 in 100,000. And in the Alaska Native population, it's 1 in 2,500. So 1 in 2,500 is a lot more than 1 in 40,000 to 1 in 100,000. So we really cherish this connection because we want to help direct more resources there, possibly look at what MLD awareness and education campaigns we can have up there to improve diagnostic rates, help improve education on genetic medicine and newborn screening, all with the ultimate purpose of getting people who are affected by leukodystrophy the healthcare that they need. We also, in the past 4 to 6 months, have had 2 families raise upwards of $1 million for gene therapy in Milan. We've been helping them crowdfund, and we've also helped with our PR team help these families get their stories out in public so that we can raise funds for them to get gene therapy in Milan. And so this also has been no small feat. And I'd also like to give a shout out to one of our US families. This is April Robson and her daughter Charlotte. What you're seeing here is a cutout from their Instagram page. April has a really wonderful online following, and she uses this following not only to show people what it's like to live with MLD, but also to raise awareness and raise funds for other organizations and other families. And last year, at the end of 2020, we had a family that came to us that has 2 children with MLD, and they were falling behind on car payments. And this vehicle was an absolute necessity to get these 2 children with MLD to treatment. And so we started a fundraiser to help pay off the rest of the car, $10,000. And once April posted on her, can we go back one page? Once April posted about the fundraiser online, the car was paid off. $10,000 was paid off in like 3 hours. So not 3 days or 3 weeks, it was 3 hours. It was an incredible thing to witness. And we're so grateful for her efforts and for the efforts of so many other families that have helped contribute towards helping others in the community. So like I said earlier, our patient registry is currently housed in our community survey, but we're making a move to a bigger and better registry, so to speak, that we're working on it with NORD. And so all of this outreach that we've been doing will be consolidated in this patient registry. And so I think one of the most unique things about this new registry that we're working on is how collaborative it is. We are working with NORD to build the registry platform, and we've also received guidance from the Global Leukodystrophy Initiative, GLIA, and we're also going to be sharing de-identified information with CHOP so that multiple parties have access to this information, which ultimately should serve to serve the greatest benefit to the community that the registry is for, the MLD community. And so otherwise, we'll continue to be using the registry for the same purposes that we have been, learning more about the MLD population and also caregivers' needs, especially too, using it as a touch point for newly diagnosed families. A lot of times families find us by just Google searching and social media, and that's just not the most reliable way to get in contact. And a lot of times time is of the essence. There's always a limited window of eligibility for patients to be a part of a clinical trial. And so that's why we hope this will streamline the way that medical professionals refer patient families to us so that we can then connect them as applicable to getting evaluated for clinical treatments and more, sometimes getting people connected to leukodystrophy care experts if there aren't any in the region that they're from. Telehealth is an amazing thing and even more amazing since COVID started. And then, of course, what we've been doing with assessing prevalence, this is sort of a byproduct of what we've been doing. So looking at how other helpful pockets of information look like what we've seen in the Irish, where we think maybe there's going to be a higher incidence of MLD in the Irish, and more. And so lastly, this is what I like to call a sneak preview of what our registry looks like, the one that we're building with NORD. Basically, you enter the registry and then you add a participant. The participant is going to be the individual with MLD, and you answer some questions on a few surveys. We have questions, demographic questions, and questions about the diagnostic journey. If you've seen our community survey, the questions are very similar. And what's great about this platform too, though, is that we can add surveys in the future to help with other studies. So looking at possibly feeding and nutrition, disease burden maybe, et cetera. And so I just want to say thank you to so many of the amazingly passionate people I've met over the past 8 months, particularly my boss, Maria. And if you ever have any questions about what CureMLD is up to, or questions about this conference in particular, you can contact me. My email is myname.melanie@curemld.com. Thank you.
Hello, everybody. My name is Laura Adang. I see many old and new friends on the list of participants today, so hello to everybody. I would like to talk today about the progress we have made on the natural history of MLD, and then also importantly to talk about where I think we can go from here and what is still needed. So I have some disclosures. I do work closely with various pharmaceutical companies to help in clinical trial readiness and drug development for the rare diseases. I serve as on the medical advisory board for multiple patient advocacy level as a board member, as well as I am funded through the NIH to do rare disease research. If you look in the literature, it seems like we understand MLD already, even though everyone on this call knows it's not true. There's these arbitrary delineations just based on age with classic characteristics where children that present early tend to have a faster disease and more motor symptoms, whereas adults tend to present with cognitive symptoms and a much longer course. And I think in general, those truths hold. But the problem is I think, is really in that juvenile group. It becomes unclear about if someone is 4, how exactly they're going to behave. And this leads us to a really tricky point where we don't always know how to predict the future. And something like a natural history study where we look agnostically, without bias, at old medical records to see what are the first symptoms that we see? Who did children first go to? Where was this missed? How can we do better as a group for both recognition as well as diagnosis? Because we're clearly catching it much later than we would like to. And I think the ultimate answer is newborn screening. And I know that's a huge effort that is ongoing. But what do we do before newborn screen is enacted in every state or even around the world? What should we be looking for as a medical community and as a family advocacy group to recognize the signs and symptoms much earlier than we do now? Also, as newborn screen arises, we're going to come up with things that we call variants of unknown significance, or new patterns of genetic mutations where we don't know how to handle it. And the more we understand the disease and the relationship between genotype and phenotype, meaning here's what your genetic code is, and this means this is your future, it will help us to both design clinical trials as well as counsel families. I think it's also really important to understand the natural history of the disease in order to design clinical trials. A clinical trial is only as good as the outcome measures you choose. If you think something is going to change and it doesn't, your drug may have worked, but you chose the wrong question. And so choosing that question is a really important thing, and natural history studies can inform that. And then the final thing that it can be used for is as a non-concurrent control. There are many situations in a rare disease where it would be unethical and just wrong to do a placebo control, meaning some children get the experimental therapy and other children do not. And there are some situations where you can just look at historical data and see what happened when a therapeutic option wasn't on the table, and do the comparison between that. And so it's a way to still demonstrate effectiveness, but not necessarily have the burden of having a group of children that get a placebo instead. And as part of our study, we have a large network, both of researchers through the GLIA CTN, as well as among family advocacy groups, many of whom are represented both as participants and callers. And through that, we have children consented to an IRB, either of their local institution or to our CHOP one. We have a centralized database with centralized training, and we extract every bit of medical information that we possibly can, and we turn it into a database. And I work really closely with programmers and statisticians to make sure that I am capturing the information in the appropriate way. And then I can turn that into data and science to better understand this disease. So with the ultimate goal of better recognizing and treating. And here's an example of some of the information that we have gotten from all of the researchers and families that have been willing to participate, is that we see that, yes, on the left, children do present young in general. So the first symptom, most children are under the age of 2. But then there's this tail where there's not really a clear jump between the late infantile and the early juvenile form, and the early juvenile and the late juvenile form. I suspect that's because this, as we look closer and closer, we see it's actually presenting earlier and in more subtle forms, and that it's easy to ignore the little things when you are seeing a child that's now having new difficulty walking. The fact they had difficulty with their vision or with eye movements or with feeding 12 months before oftentimes gets lost in that first medical visit. We can start to look at things like what symptoms the children first have, and this would allow us to potentially target different subspecialists to create awareness about MLD. So if we find, for example, many families first went to an ophthalmologist or an orthopedic surgeon, maybe we should be doing targeted teaching towards those subgroups who wouldn't normally see MLD and wouldn't normally recognize it. And this will help us get to a diagnosis faster. One of the projects I'm most excited about is looking at early milestones in the MLD population. This is a plot where the age at which a child first had their clear symptom from MLD is plotted on the x-axis, and on the y-axis is the age at which the child began to walk well. If it's a purple dot, it's the age at which they began walking. And if it's a red open circle, this is our children that have never learned to walk, and the dot is placed at the age at which they we have their last data point within our registry. And the takeaway from here is that many children with MLD do learn to walk. Many of them learn to walk actually later than expected, so that would be a good early warning flag for MLD. But there's actually a subset of children, about a quarter of them, that with MLD never learned how to walk. This is really important because many clinical trials currently require children with MLD to still be walking. Well, if we know a quarter of children are never reaching walking, A, we're probably getting to it and identifying it too late, and B, maybe there would be an opportunity for designing a clinical trial around children before the age they were supposed to be walking, or including children that have symptoms of MLD but are not walking, but are mobile in other ways. And so I think as we understand the data better, it becomes important to tease out these like nuances that were missed before. We can start to divide the data and the cohorts into, well, when did you first present with symptoms? Before 2.5 years or after 2.5 years? And then look at trends of, when did children lose the ability to walk, or when was a G-tube first placed? And we can start to better understand the data, not as locked in by the ideas of late infantile or juvenile or adult form, but really taking the data more organically and letting it speak for itself. So in conclusion, hopefully you'll agree with me that MLD is a spectrum disorder that doesn't so neatly bin into these three categories based on age at presentation. Clearly, age at onset is a very important factor, but I think things like presentation features can help us to better understand both course and outcomes. There are better diagnostic and treatment horizons on the really near horizon. And I want this natural history data to help us to kind of prepare for the future, both with counseling families in the medical clinic, targeting different providers for potentially recognizing and helping children with MLD, as well as designing future clinical trials. And this work is part of a much larger consortium that is all part of the GLIA CTN network. So I wanted to also thank all of my collaborators on that front as well. Thank you.
Good morning. My name is Lesa Brackbill, and I live in Hershey, Pennsylvania. I am a wife, mother, author, and advocate. I'm here to talk to you briefly today about newborn screening for leukodystrophies and how you can get involved. But first, I wanted to briefly share part of my story and how I got involved 6 years ago. It wasn't a journey that I willingly began, but I'm definitely determined to make the most of it. On February 13th, 2015, my life changed forever when I found out that my firstborn daughter, Tori, had a terminal disease called Krabbe leukodystrophy. She was just 6.5 months old at diagnosis, which was by far the worst day of my life. Not long after diagnosis, my life changed again when I found out that they could have treated it had she been screened for Krabbe at birth. That information began the journey that has led me to this place, speaking to you today about advocacy for newborn screening. Can you advance the slide, please? When Tori was born, I knew they had pricked her heel for a test, but I wasn't certain what it was. In fact, I remember saying to my husband a couple of weeks later that everything must be okay because we hadn't heard anything from whatever that test was. Unfortunately, that wasn't the case for us. Shortly after diagnosis, I learned that Pennsylvania did have a law in place to test for Krabbe at birth thanks to another Krabbe family, but that it had never been implemented due to some complicated loopholes. I began attending the state's newborn screening technical advisory board meetings just 3 weeks after Tori died, and I still attend to this day. I learned that the Pennsylvania Newborn Screening Board has the authority to add conditions without legislation, and that they thoroughly evaluate each potential condition to assure that it's ethical to screen for it, that the screening test is accurate, that the condition can be effectively treated, and that long-term outcomes are positive. Pennsylvania is unique in many ways, and its newborn screening program was no exception. Not only was it a complicated 2-panel system with only 10 conditions being mandatory, I realized as I attended meeting after meeting that Pennsylvania had an even bigger problem. Screening wasn't equal from hospital to hospital. So that meant that more than ever, life or death was determined by zip code here, and I knew I had to change that. I have the advantage of having a political science degree, experience in politics, and in lobbying. So it became clear that I was the one for the job and that this was what I was created to do. In our case, legislation was the way that we had to go because of the existing loopholes. It took 4 years, 3 bills, 2 of which failed, hundreds of emails, phone calls, and meetings. But on November 25th, 2020, my legislation was signed into law, making screening equal from hospital to hospital, increasing the number of conditions on the panel, making Pennsylvania RUSP compliant, allowing the Newborn Screening Advisory Board to more easily add conditions like MLD someday soon, and most importantly to our family, making Krabbe screening mandatory by default. On May 24th, 2021, Pennsylvania will become the 9th state to screen every baby for Krabbe, and I am so proud of that. This is Tori's legacy, and because of that, this is the greatest accomplishment of my life. I'm so grateful for all of the lives that will be saved by this law. Through the last 4 years, I learned a great deal about advocacy, about the legislative process in Pennsylvania specifically, and about newborn screening. I learned that sometimes the answer isn't legislation, and sometimes the newborn screening problems that need to be solved in a state will result in leukodystrophy newborn screening by default, as was the case for me. I knew I didn't want that knowledge to go to waste, though I wanted to go into retirement. So when Maria approached me last spring with an idea that she had, I knew that was the next step for me. She had an idea to form a coalition of advocates and organizations for leukodystrophy newborn screening to work together instead of separately, to share knowledge instead of continually reinventing the wheel. I myself had observed that many leukodystrophy organizations seemed to work individually, and that the efforts to add leukodystrophies to newborn screening panels seemed fragmented and inefficient. So with that, we launched LDNBS.org on December 31st, 2020. Our mission statement is this. Next slide. The Leukodystrophy Newborn Screening Action Network is a coalition of leukodystrophy patient advocates dedicated to championing the cause of newborn screening for leukodystrophies and lysosomal storage disorders. We do not believe in wasting time and resources by starting from scratch with each new disorder. Instead, we want to build partnership across the dozens of leukodystrophy groups so that we can work together, coordinate our efforts, share resources and information, and advance the goal of newborn screening for our entire family of disorders around the world. LDNBS Action Network isn't about me or what I know. It's about what we all collectively know. We are currently in the process of developing content, collecting resources, and talking to advocates about their experiences because that's where the knowledge lies. We are constantly watching for related news, published papers, and anything else that can help advocates do this work. We want this site to be the best resource out there for anyone wanting to take on this mission in their state. To assist with this, the website has up-to-date maps for ALD, MLD, and Krabbe currently, so you can see easily which states are screening for which disorders. This is the map for ALD, for example. You may have heard of the Federal Recommended Uniform Screening Panel, or the RUSP. If not, it's the goal of every newborn screening detectable disease to be added to that list to make advocacy a little easier, because many states prefer to only add conditions that are on the RUSP. But did you know that even when a disease is added to the RUSP, you still have to advocate it for most states to add it? ALD was added to the RUSP in 2015, and less than 20 states are actively screening today. This reality means that our work for ALD, Krabbe, and soon MLD is far from complete even after RUSP addition. Our maps are a great place for advocates to start. They allow for a broad overview for each leukodystrophy, and when you click on each state, you will find useful information regarding the process in each state. Things like, does the state require legislation to add conditions, or can the Newborn Screening Advisory Board make that decision? Does the legislature have a rare disease caucus to help find a sponsor and to support you in advancing the legislation? I spent many hours compiling the best and most useful information I could so that advocates will be as equipped as possible after visiting our site or talking to us. We even compiled a list of all of the known books written by leukodystrophy families, as well as documentaries to help equip families. These aren't textbooks. These are real stories of real families and their journeys, and this information can be incredibly helpful as you advocate. We've also taken the time to compile an extensive list of frequently asked questions, and we will continue to add to this list as we become aware of more, to assist advocates with the tough questions that may come their way. Second only to the maps, my favorite resource is something we call the 3 pillars of newborn screening advocacy. We encourage advocates to know their disease, know their state, and know their story. Knowing their disease helps to guide the advocate with where to start. Is there even a newborn screening test and a viable treatment for their particular leukodystrophy? What data and information is important to know? Knowing their state helps the advocate decide which path is right for their state, legislation or the Newborn Screening Advisory Board. It helps prepare for both situations, as sometimes you do have to try both ways. Legislation is the more difficult way in most situations, so we encourage advocates to speak with their Department of Health first. And finally, knowing their story is the key to the entire advocacy mission. It is our stories as parents and families that drive the point home. It can be intimidating to share these stories, so we wanted to help advocates focus on a few main ideas to help put them at ease. We ordered these purposefully, knowing the specific disease well is crucial, because if there's no newborn screening test or treatment, then advocacy is futile. Knowing your state is next because it helps determine your path of advocacy. And knowing your story is the last step because it's the easiest. You've already lived it. Now that my legislation is law in Pennsylvania, my mission is to help mentor and guide anyone else who wants to advance leukodystrophy newborn screening in their state. It can be confusing, overwhelming, and intimidating, even for people with experience. So I want to walk alongside families and do whatever I can as they do this important work. LDNBS Action Network has hit the ground running and is already working to connect advocates in each state, to assess state priorities, and to prepare for the future edition of MLD. We're sharing advice and learning from experienced advocates, offering leadership grants, and preparing for a newborn screening boot camp. Advocacy takes a lot of work, but it's also an emotional experience for those of us who are parents of leukodystrophy children. That's why we're here, to make the work a little easier and the burden a little less heavy. We may not have every answer quite yet, but we do usually know where to find them and who to ask, and we're ready to do the work. With research and clinical trials happening at a fairly rapid pace these days, and with industry being an unexpected ally in adding conditions to newborn screening, it's more important than ever that we advocate for these leukodystrophies to be screened for in every state and eventually every country. It is our hope that by working together, we can truly change the world. Thank you.
Hello, everybody. Good morning, afternoon, evening, wherever you are. My name is Dr. Al Freedman, coming to you live from picturesque Westchester, Pennsylvania, outside of Philadelphia. That was a wonderful presentation. I really enjoyed it, all of them, and I'm honored to be here. I am both a practicing psychologist, and I'm also the father of an adult son who's affected by a different neuromuscular disease, spinal muscular atrophy. SMA. My son Jack was given a year to live when he was diagnosed with SMA back in 1995. And he's now 25 years old, and I'm very, very lucky to have him. And just as many of you have become involved in your national support group, your MLD group, I've been involved for about 20 years, contributing my set of skills to the group in support of other families. And I've been very privileged and honored to work with our SMA families for many, many years at our national conferences and other programs, offering emotional support as a counseling psychologist. Over the years, I've, for our SMA community, offered many workshops and led many groups for parents who have newly diagnosed children, groups for fathers of SMA kids, very special opportunity each year to facilitate groups for the affected children themselves, and groups for young adults. And I've provided individual counseling support for many years to SMA families, both nationally and internationally. And recently, because of the pandemic, I've had the privilege of being able to offer support to our SMA families as far away as Australia and Russia. Also, in the past couple of years, I've been consulting and speaking, helping others in industry, other rare disease organizations, and NORD to understand the emotional and mental health needs of our rare disease families, and have offered my support to these various groups and organizations and industry to teach others and train others how to support families like mine and like many of yours and those you're supporting. I was honored to be asked by Maria to be involved with Cure MLD to provide some direct support to your families. And we're in the early stages now of providing emotional support to MLD families in both individual and group situations. So I'm just going to share with you for a few minutes, some reflections on what I've seen, what I've learned, and what we're offering to our MLD families. And I'm learning a great deal from the families, as I expected I would. First, individual support has been offered to both families with diagnosed children and families who have had a diagnosis of MLD for a while. and I've interacted with a number of families over the past month or so at an individual level. Second, we are now offering support group meetings. We have, over the past year or so, had a number of family support meetings where families from around the world are together virtually on Zoom to share their experience with each other and to receive support from each other, with me facilitating those groups. And very recently, last week, we had our first social hour for MLD affected adults, which was an experiment, and it went beautifully. And what a privilege it was to have an hour with a number of adults around the United States who are affected by MLD. Finally, there is a collaboration underway with NIH-funded Screen Plus project in the state of New York, where families who are diagnosed with a number of rare diseases, 14 of them, I believe, are offered family coaching support at no cost to them that I'll be offering to provide. That program has just begun, and it's a very exciting opportunity to have access for families who find themselves in these unusual situations diagnostically, to have the opportunity to have emotional support. And I'm just going to share on my own here without a slide. That's my only slide. What I want to share with you now is just a few lessons that I've learned, both from personal experience as the father of a young man with a neuromuscular disease, and also obviously as a professional. What the families affected by MLD have taught me in the short time I've been involved is very consistent with what I've seen with SMA and other rare diseases. First, a diagnosis of a rare disease is truly a trauma for the entire family. A trauma that takes a lot of time to adjust to. Families need to know that their psychological response to a diagnosis is normal. Many families who contact me ask me, Dr. Al, is this normal? Is it normal that I can't sleep at night? Is it normal that I'm scared? Is it normal that I'm crying all the time? Is it normal that I'm depressed? Is it normal that my appetite is not what it used to be? And these families need to know, as I needed to be reassured, that the psychological response is normal given the acute stress that comes with having our lives turned upside down with this kind of diagnosis. It takes time to adjust to a diagnosis of MLD and any rare disease. And it also takes time to move from a place of fear to a place of hope. It takes time to recognize that you'll have good days too when you have a child or family member affected by this type of condition. It takes time also for some families to accept help. There have been a number of families who've been offered support and who haven't chosen to accept it. And that's because many families just aren't ready yet and need time to get used to this new world that they've been launched into, that they weren't prepared for. Something else that I'm learning from our MLD families doesn't surprise me. They're all in search of professionals who know more about the disease than they do, and professionals who show they care. And as I'm interacting with the MLD families in your community, I'm hearing many of the same doctors' names being mentioned. This is a very rare disease, and there are very few doctors who know a lot about it. So families tend to search out doctors who do, understandably. One of the things that I was told when my son was diagnosed was, don't worry, Al, you'll become the expert on SMA and you'll teach us a lot about it. And I remember being scared and thinking, well, I don't want to be the expert on SMA. I don't really want to be in this situation. I need people who know more about this than I do. So all families are searching for professionals who can comfort them, provide them with medical support and knowledge that they all need as they're adjusting to the situation. Another point I'd like to highlight is that caring for a family's emotional needs is often, and it's understandably, secondary to managing the medical needs of the patient. And this has been true within the SMA community. We're all trying to pay attention to the quality of life and the safety of family members. So the medical focus is understandably primary, but our families obviously have many psychosocial needs and do need support as well, and they need permission to have that support. So I'm privileged to be a small part of offering what can be offered to families in this situation. Another obvious point that I'd like to make that I'm noticing is that when you have a rare disease, it's indeed a rare experience, and other people can't relate. So our MLD families experience isolation, and now we're in the middle of a pandemic, which makes that isolation even more pronounced. So families are really hungry for contact with the world, for their family members, with the world, and with each other. The families that I'm interacting with through our MLD groups are so grateful for the opportunity to connect with each other, to receive each other's support, to have that connection, which makes everybody feel less isolated and builds a sense of strength as expertise is shared, and this shared experience, which is so unusual and so hard for others to be able to relate to, is able to be shared among people who do understand. And this has been my experience also as an SMA dad, that the best support I get are from other families who are in a similar situation. Another point I'd like to make is, before I finish, is that as a psychologist, I can tell you that there is often an assumption that when a person with a rare disease or a family member affected by a rare disease has psychological issues or symptoms, that it's 100% due to the stress of the rare disease. And that's often the case. But rare disease doesn't discriminate, and there are people who have mental health issues prior to a diagnosis of MLD or another neuromuscular disease. So we have to be careful to tease out what is a situationally driven symptom and what might be a medically driven symptom that was pre-existing. And that can obviously present a complicated set of challenges that I've seen before and have helped with before. Finally, I'd just like to say what a privilege it is to be trusted to support your family members. What an honor and a privilege it is for me to have the opportunity to provide a direct care. As much of my work these days is consulting and training others how to provide care. And I feel very honored to be serving your community in this way. I'm learning a lot. And each time I have an interaction with members of the community by providing direct support, I'm learning more about MLD, and I'm humbled to be part of this and privileged to support you all. And thank you for having me today. And thanks for this opportunity.
Well, thank you, Dr. Allen. Thanks to all the panelists. I don't know about all of you listening, but I'm so overwhelmed in a good way by all of the information and all the great work going on. So I'm going to ask now that the panelists come back on. We're going to move to our Q&A portion of the standards of care meeting. And in the first portion, I'm going to throw out some questions. Questions that are kind of pre-written, and I want to encourage everyone listening, please, as you think of questions, put them in the Q&A and we'll get to those. I see some coming through, which is great. I encourage more of you to put your questions in the question box. There's probably a lot of questions out there, so don't be shy. So I want to kind of kick off. Dr. Al, I'm going to direct this first question toward you, but then I want the rest of you to kind of react to this question. Kind of apply the MLD community. So one of the things that we anticipate, and I know the SMA community has faced this, is can you tell us a little bit about the challenges of managing a community and sort of navigating a community where, and some of the challenges that has come through the dynamics when you have some families who received a diagnosis very late for their child, and some families are receiving that diagnosis in the newborn screening. So you've got this community that's made up of people that have likely had very different experiences in terms of how long it took to get a diagnosis, what the disease progression has been. Can you talk about that a little bit? And then I'm going to ask the other panelists to talk about ways you think we can address these challenges proactively as Dr. Al talks. So Dr. Al, if you could kick off your thoughts. I know you've alluded to this before.
Yeah, sure. So broadly speaking, our SMA community is very fortunate in that not only has newborn screening been around for a while and is being used in a majority of the states in this country, but we now have 3 FDA-approved treatments. Not 1, not 2, but 3. And so the landscape has entirely changed for our community. And with the miracle of scientific progress comes some unanticipated challenges and some complex ethical challenges because of access to newborn screening for some but not all, and access to treatment for some but not all. So I'm giving you a broad answer to that question to start. In terms of psychological experience, to have a child diagnosed based on symptoms is different than having a child diagnosed through a newborn screening process. And one of the things that is very hard and confusing for families is to have a baby who looks perfectly normal, who acts perfectly normal, but to be told that the baby has a life-threatening, incurable disease. That is very confusing. That was how I felt when my son was diagnosed, because he didn't show symptoms that were that evident to us. He wasn't screened at birth, but he looked okay. So it's a very disorienting feeling for families to be in that position. As things unfold, you're going to hopefully have the wonderful problem of having treatments and some who have access to treatments through clinical trials and through insurance and other means, and others who don't. And to answer your question, I think the important thing for the MLD community is to plan ahead. When I talk to the leaders of our SMA community, what I'm told, the reflections we all have, is it was helpful to plan ahead, to know that there will be different groups of families in different circumstances, a wide range of circumstances. In our SMA community, we now have 4 or 5 very different groups. We have groups of adults with SMA, a group of adults with SMA. We have a group of kids who are diagnosed before there was newborn screening based on symptoms. We have kids who are diagnosed based on symptoms now in states where there isn't newborn screening. And we have a group of babies who are diagnosed through newborn screening. And we have babies diagnosed prenatally. So there are about 5 different groups. And if you think about each of those groups, they're going to have different psychological responses, and they're going to have different needs socially. They're going to have different needs medically. And we, I think, as a community, are working hard to make sure that there's a place for everyone in the community, regardless of the context that they're part of the community. There are some challenges when families, it's a great problem when a family has a baby screened at birth and is treated early and they're treated effectively. They might not feel like they need to be part of the group. And so we're, as a community, trying to make sure that everybody feels comfortable being part of a group. And finally, there is some survivor's guilt when there are families who have babies who are treated effectively. They sometimes stay back from the rest of the group, thinking that people like me, for instance, who has a young man with a wheelchair and a ventilator, are going to be upset that we didn't get the same help. And in fact, we're celebrating the progress. So we have to anticipate these different groups, their experiences, their needs, and make sure that there's room in the community for everybody. I hope that's helpful.
Yes, absolutely. That was incredibly helpful, Dr. Allen. So now I kind of want to open it up to the rest of the panel to kind of, if anybody has any reactions to what Dr. Al said. So what are things that we in the MLD community can do to be proactive, or things that we are doing and thinking ahead on? to kind of address these very real things. One of the things I just want to kind of put a pin in something I hadn't thought about was, my brain was going to families diagnosed with newborn screening and families not diagnosed, but I didn't even think about the equity issues, and maybe Lesa, you can speak to this, even within, the official newborn screening edition, it's going to be so uneven. So I want to know if anybody on the panel wants to react to some of what Dr. Al said.
Yeah, I think, Dr. Al, I echo all of your thoughts. I think creating a platform that serves families where they are and making sure it's accessible. I think different families want different levels of information at different times in their journey, and making sure we offer a variety of group support, individual support, written materials, and covering our bases and making it really clear and obvious where that is, and that we're here for them wherever they are in that kind of emotional journey. And I echo your sentiments, Dr. Al, from my ALD experience. I think offering unique support platforms for families identified through newborn screen versus through family history or through other ways. I think the journey is stressful and unique and horrible in all directions. So I think supporting our families in every way we can, and not expecting anyone, even with the same type of MLD, to have the same type of journeys, because I think as families, we all have different barriers and places and support networks.
And then, so also speaking from the perspective of the Leukodystrophy Newborn Screening Action Network, which I've collaborated with Lesa on, looking at where states are in the process of adding conditions to a panel, sometimes we need to build up the infrastructure in the state first, because newborn screening, it's not just the test itself, it's the comprehensive system as a whole, where you have professional intervention at all points in the process. And so getting the technology that the states need, getting the labs up to speed so that when newborn screening does happen, everybody's prepared, and we try to mitigate as much stress and uncertainty as possible, because that is where newborn screening sometimes comes under fire, is when the families are subject to uncertainty in their diagnoses, or the time that it takes to get to diagnoses. So just getting the infrastructure prepped beforehand is also really important.
And I would also like to say, figuring out how to do a newborn screen and implementing it is only half the journey. I think also coming up with a clinical consensus on what you do with that information is something we're starting to work on, but I think it's not always as clear as it seems like it should be. I think in MLD that it definitely is that circumstance where we need to meet as physician groups and experts to really decide what are we going to do across the board to make sure that if a child in Pennsylvania and a child in Maryland are both diagnosed, that they get the same standard of care once we identify a patient. So I think that is also important to have in place on the early side.
So Dr. Adang, I want to kind of follow up on what you're saying here. I think you're kind of speaking to this. So I'll ask you, and again, the panel is welcome to weigh in. Talk to me a little bit about follow-up. So with that screening, so when a child is screened, do you have thoughts or advice on for state follow-up? Who should be, and we know that follow-up is going to vary, so knowing that there might be a lag, right? A child is identified, and then there may not be symptoms that present for a while. Who would you say is best equipped to do that follow-up and to keep, who's responsible to do that? And do you have lessons learned from the ALD community that you could share with us?
Yeah, I think it's a great question. I'm going to hedge a little bit because I think it really is going to be state by state, right? We're lucky that the newborn screen comes with a set platform, and there are actually formal places where when you have a an abnormal newborn screen, it goes to specific centers and specific doctors that are designated referral centers for the most part. So I think that we have an infrastructure to benefit from, but I think it's really critical in the community. When do you start doing MRIs, right? When do you start doing these interventions? I think they're very easy to put on paper, but you want to make sure that you catch all the information you absolutely need, but you're also not over medicalizing or instrumenting and making children go through processes that aren't necessary. And so I think it's really coming up with a big consensus from larger meetings than just this panel to really decide what is best practice. In ALD, it's been a work in progress, and it's been a beautiful collaboration across many states and honestly many countries to come up with the best guidelines. And it's a work in progress. We have learned a lot from the children we have identified about who we need to screen and how often we need to screen. I think the general approach is you start very conservative, right? You screen very aggressively for brain involvement, for abnormalities. And then as you better understand it and understand the subtypes that are more or less at risk at various ages, you can start to adapt it. And that's what we've had. And I think it's being honest with the families that we have a consensus guideline that's based on what we know, not what we don't know yet, right? And so it's an evolving process as we really try to do the best for our families, balancing not making them live in the hospital to get constant tests, but also making sure we intervene at the exact moment where it's really optimal to join in. And I think as different therapeutic opportunities are FDA approved in the United States, we'll have a lot more in our arsenal. And so I think we'll have a clearer path. At the moment, we do not have easy gene therapy. So I think it's a harder thing to make a national platform around something that's not FDA approved.
That's really helpful. And again, I'll do a follow-up question for you, Dr. Adang, but anyone can also jump in. And Dr. Al, maybe you can, again, sort of following this model of trying to learn from the SMA community, and Lesa too, anyone just jump in. But as you talk about this follow-up, and I'm hearing this, what role do you think advocacy groups can play in that support? You know, when do we come in? When do we have as there examples, Melanie, of times that, you know, advocacy groups have come in effectively? Do you have any thoughts on that? And Dr. Al, feel free to chime in with the SMA community.
So speaking from the MLD perspective, obviously this is something that we're still very new to. So I would also invite Al and Dr. Adang to talk more about this, but this would also be something that would be interesting to hear more about from our panelists on session 2. So I just want to plug that real quick to our session 2 is next Friday, it's all about newborn screening, and we'll have Dr. Melissa Wasserstein, who is going to be talking about the Screen Plus program, which is the first MLD newborn screening pilot that's happening in the US. And so all of what we're talking about today, which is what we've learned so far from other communities, it'll be interesting to hear too, from her perspective and from the others on that panel, how they will handle MLD newborn screening.
So I'm jumping ahead a little bit, huh, Melanie?
Maybe just a tad.
I couldn't help myself. I should stick to the script.
I mean, we'll come in. So we're working with Screen Plus, and Dr. Al has spoken about this too. We're working with Screen Plus to at least provide the babies that will be the families that are identified through Screen Plus, provide them psychological support. So that's one way that I guess advocacy can intervene. The element of psychological support, I think maybe historically has been lacking, and so that's why we're trying to fill in that gap.
Great.
In terms of the SMA community experience, I think what you're doing now is exactly what the SMA community has done, perhaps at a larger scale, as it's a less rare disease and has been established for many years, bringing people together at the national conference. There's a larger group of people that our advocacy group brings together each year to put heads together. We have a family conference side by side with a research conference, And I'm a member of the Medical Advisory Council as well. And by getting people in the same room together, which now happens virtually this past year, it provides the opportunity for discussions like this to be more formalized. And the QRSMA has sponsored this research conference and family conference for many years in an effort to bring people together and to pool resources to answer questions like this, because this is all a pioneering effort. It's uncharted territory. So the best way to deal with uncharted territory is to bring people together to be collective in the effort. And certainly it's a more challenging set of conditions with a disease that's less common, much less common. So there are fewer people involved, but the people who are involved, bring them together. It's what you're doing right now.
Great, thank you. So now I'm gonna ask a question about the natural history study. So again, Dr. Adang, I feel like I'm picking on you. I can't, I promise I won't lead off with you every time. Can you tell us a little bit about how the MLD natural history study has influenced the development of current treatments and how it will be used to develop future ones?
Yeah, thank you, Erica. So I think one of the big things that it has helped me to do is kind of join a network of researchers and clinicians who are interested in helping families that are affected by MLD. And that's a really important thing. I think historically we have lived in silos in academics, in industry, and I think building the bridges across different groups is essential. We know our families have given more than is fair to ask of them to their own families, to medical care, and then also to be part of research is a lot to ask. And so I think it's unconscionable to expect for groups to not talk to each other and share information and be collaborative. And so I think that's one of the big things that it has taught me, is the importance of building these large international networks so that we can talk and have group meetings and everyone feels that like they are invested and involved, because that's how we're going to move things forward. As far as, I think the biggest takeaway that I've come from as far as changing my understanding is understanding it's probably starting earlier than I thought it was, right? If you read in the literature, it seems like it's really 18 months. And I think it's subtle before it really starts having change with the neurologic symptoms. And to me, that's that key window. That's when you want to make sure you have intervened at or before that point, right? You want to have that window because it lets you know, okay, it's real, it's happening, let's do this. And in an ALD, that's been the general successful stance, is that you, because you don't know what form it's going to take, you wait until you are certain it's going to change in the brain before you do an aggressive intervention. And so identifying those early warning signs is a really nice way to be certain that you're intervening at the appropriate time on the appropriate group of people, right? So I think in my mind, it's started to change that nuance. It's seeing the signs on the wall before they're really clearly written. It's being able to go through the detailed medical notes before they see a neurologist to see the things that may have been subtle and missed, is a really heart-wrenching part of science, but I think it's a really important part to move forward, because if you start all natural history studies at the point at which you're diagnosed with MLD or a rare disease, you're probably starting at months to maybe even years after the disease actually began. And so it's really important to understand what happened. Why was there such a delay in diagnosis from when the family had concerns to when the doctors had concerns? And what patterns can we pull out to start informing various groups that you should be worried when you see this cluster of symptoms? And then how do we target education to doctors and families about what to look for?
That was really helpful. And I just want to take a minute to pull out something you said, Dr. Adang, you know, for any families who might be on this Standards of Care webinar, I just want to thank all the families who've participated in the natural history study. I know it's, like you said, Dr. Adang, you know, we ask for information from these families who are already in, you know, incredibly in the thick of things and managing, and we're just so grateful as a community that families are willing to participate and contribute their child's information to bettering science. So I just really felt the need to say that big thank you. Does any other panelist have anything to add in terms of natural history study and engagement with natural history studies, or any questions they want to ask Dr. Adang before I move on?
I just wanted to say that I appreciated the presentation that you gave, Dr. Adang, and the mention that these symptoms are starting earlier than what maybe was previously thought, and even looking at the spectrum from looking at the juvenile and the adult onset, how that kind of blurs together, because that's something that I can echo that I've noticed in my advocacy work or working with families, is that they go through oftentimes years of misdiagnoses because of the way the symptoms present as, you know, ADHD, other behavioral problems, psychosis, mental health disorders. So I just wanted to echo that we're seeing that too in the advocacy space, and that was really interesting.
Great, and you both kind of spoke to the power of these natural history studies and how much they can inform us, which will also inform us leading forward as we work with newborn screening. So speaking of that, I'm gonna dovetail into some questions. Lesa, I'm gonna put you here on the spot, and some of my question is you sort of touched on in your presentation, but I want to distill it a little bit. So the first question I have for you, Lesa, is, you know, even in my own advocacy, patient advocates are often really encouraged to tell our story, and that's super powerful. And I think that it's the starting point, right? And the personal story is so powerful for legislators. But, you know, what would you say? What advice would you give for someone who potentially has never? You kind of had the benefit of being, you know, in political science as a major, and you said you'd had some experience with advocating already. Some of those families, and by those families I mean myself, when you get involved, maybe don't have that background. What would you say, beyond being prepared to tell your personal story, what should families be prepared for next, or what are some of those tangible things they can do to really move the dial forward with newborn screening?
So there are a few things that come to mind. The first would be, like I mentioned, making sure that you know your disease, you know the status of the newborn screening test, the treatment, the FDA approval, all those different things. Knowing your state, which I would also say includes talking to other people within your state, because there are people who have likely gone before you, but probably for a different leukodystrophy. But the process is still the same. The lessons are the same. And that is exactly why we wanted to start this collaboration, and why we're trying to connect people within states, even across leukodystrophies, because it's so important that we learn from each other. So even while the MLD families are waiting, because obviously we don't have newborn screening data yet that we can really move forward with, we can be making those connections, making sure we understand how our state operates, making sure we know our disease inside and out. And then as the data comes in, then you're just supplementing everything you've already done. So like you're ready to go. You're just waiting for the data to be able to present and say, here you go. Especially with the newborn screening advisory board, they also like published papers and all that stuff. So that way you're ready to go. You're just kind of waiting for the science, like the published science to come through to prove your point. So there's always things that you can be doing, but there is a lot of hurry up and wait. So you have to be prepared for that as well.
You had mentioned that your state had like an advisory panel, so you didn't have to wait for legislation. They would add things to the newborn screening. Can you say a few words about how to first, again, I think sometimes advocates, and maybe I'm just speaking from my own experience, can be very intimidated to start engaging with scientists and MDH or for me, Department of Health, you kind of feel a little overwhelmed. How easy or hard was it for you to engage with that panel? Could you give a little bit of information.
It's actually kind of funny because at least in Pennsylvania, the meetings are open to the public. So my very first meeting was 3 weeks after Tori died. It just happens to be when it fell. And so my dad and I went to this meeting and they didn't know who I was or why I was there. Because at least in Pennsylvania, the public comment time isn't for about 5 hours. It's a very long all-day meeting here. Anyway, so the very first thing on the agenda, and this was in April 2016, was about how Hershey Medical Center, which is our hospital, was going to begin screening for Krabbe and for Pompe and MPS 1 and a few other things. And the chair of the committee, he quickly became not my favorite person, though now we're on the same team, and that's why I'm telling this story. He had no idea that I was there because of Krabbe, and he was talking about what a waste of time it was, and he couldn't believe that they were going to spend the money to do this. And I am angry, but I can't talk for 5 hours, so that actually was beneficial. So I was able to formulate what I wanted to say. But truly, from the beginning of that meeting, I thought, this is never going to happen. But I have consistently shown up. It's every 3 months or so in Pennsylvania. I've shown up. Every time something was published, I emailed it directly to them. So now I feel like I'm a part of the group, even though I'm not. They just can't get rid of me. But it took that. It took consistency. It took them seeing that I did know what I was talking about, because even amongst any leukodystrophy, we as parents know what's happening before the doctors often do, because we are at these conferences. We hear all these things, but if it's not published, at least here, they don't care. So I also felt some satisfaction with passing along those reports. So that's what it took for me, was just proving that I was in this for the long haul, showing them the research that came in to prove that this was worth adding. And now we're at the point where they're getting ready. Like, we just had a meeting a couple weeks ago where they're going through the algorithm for Krabbe, and they're preparing for May 24th. So I would say, yes, it is intimidating at first, but most of the states' meetings should be open to the public, and it's worth going, because what do you have to lose?
I love that. And as you were talking, I just sort of, some keywords popped into my head. Tenacity is what I'm hearing. It takes some tenacity, content knowledge, having some content knowledge, and sort of some qualitative data, right? Sometimes we think of quantitative data, but it sounds like this qualitative knowledge too. Does anybody else on the panel want to kind of react to that question or add any thoughts?
Yeah, so I've been working with Lesa on the Leukodystrophy Newborn Screening Action Network, and so we've had lots of discussions about this too. And so I think one of the biggest misconceptions that I often hear is that people think that you need to go to legislation first to pass, to add a condition to a panel. And as Lesa was saying, a lot of times that's not the case. You can go to the NBS advisory board, and if the meetings are open to the public, why not? But also to make the experience overall less overwhelming. I mean, that's why the Action Network exists. And also that's why we really encourage people to make connections with others, and not just to learn from them, but even if, so like the state of MLD is that, Screen Plus has just started. So we're sort of playing a waiting game, but we're prepping on the sidelines as well. And part of this prep can even be getting on board with, if there's other leukodystrophy newborn screening efforts in the state. So some states have passed both ALD and CRAB, and have added both of those conditions to the panel. A lot of states are still working on one or both of those. And if you can get wind of those efforts, or even get in touch with us and we can get wind of those efforts, as Lesa said, we may not know everything, but we know how to get what you might need to know. And so getting on board with those teams and learning and working with them to see how, not only how they did it, but see how maybe you can repeat these efforts for MLD, it is also a really good strategy too.
So I'll ask kind of a follow-up question to what you're saying about find people in your state. And again, Lesa, and I'm hoping Dr. Al, that you would know a little bit from the SMA community. One of the things that I found in my own advocacy, kind of related to the rare disease space, not directly leukodystrophies, but coalition building, and really building as robust of a coalition as you can find, Does anyone on this panel have any thoughts on, and any tips for advocates who want to work in the newborn screening space? Are there other groups or organizations that tend to be supportive of newborn screening that kind of think out of the box, not just our own leukodystrophy community, but I'm thinking, hospitals, medical associations. Do any of you have advice and thoughts on that?
I just have one thing to add, and then I'll let other people talk. But
Yeah.
one thing that I've been very surprised to learn is that industry, though they have a vested interest in newborn screening, because that's why they're developing these treatments, is to be able to treat these babies, they might not know how much they actually need to care. But when they do care, they also have funding and they have power that can really assist us in, and I don't mean money as in like paying legislators. I just mean they have the capability, they have the know-how. And so if we can get them to realize that they should be working with us, it can be a huge, huge asset.
Great, great.
Yeah, I completely agree with that. I think the other thing is to recognize that it's every single state, and that RUSP is a recommendation panel, but it is not a mandate. And so whether something goes through the RUSP or not, every single state needs to be individually advocated for. And so don't assume that because it went through on a national level, it will mean that it gets implemented. So really having those discussions in every single state is a really important part of the process. Unfortunately, it's not an automated thing. Right? The RUSP is much more of a scientific evaluation of the evidence behind using it. It is not a implementation or financing on the state level.
Great, that was great to pull out. Oh, good. Dr. Al, I was hoping you'd jump in.
Oh, just to comment that I'd like to echo what Dr. Adang said, that within the SMA community, newborn screening is now a part of, I think, I've lost track, but 30 some states, majority of states in the United States, and it is a state by state advocacy effort. Each state makes its own decision, and that's a process that's taken some years. And I believe in our SMA community, there's a sense that another 2 years will be needed for SMA to be screened in all 50 states. That it's in process at a state by state level. And also, to echo what Lesa said, I'm well aware that industry is motivated and interested in helping to have newborn screening in every state, because now there are treatments that can be provided to SMA babies right away that are only effective or as effective when the baby is treated at birth. So the advocacy departments within industry are actively involved in supporting the effort along with the community. Because it's in everybody's best interest and theirs for babies to be screened early in order for the treatment to be chosen and effective, most effective.
And can I ask a quick follow-up, Dr. Al? Do you know of in the SMA communities, has there been support from, medical associations or other nonprofits that advocates can lean on, or is it?
I can't tell you that I've been centrally involved in this effort, so I wouldn't want to guess wrong. I can certainly find out from my friends, but it's not something I've been involved with directly, so I'm afraid I can't offer more than I have about the newborn screening advocacy.
Off the top of my head, I'm sure Lesa probably knows the names of more organizations as well, but Every Life, Baby's First Test, these are resources that we often use to look up information for the LDNBS Action Network as well. Yeah, and also sometimes advocates can come in like less obvious forms. Recently, we were in contact with an advocate who was interested in MLD newborn screening in North Carolina, and we were trying to connect this advocate to the ALD advocates who have helped pass or add ALD to the panel down there. And actually, we found out that the efforts for ALD in North Carolina were largely done by a lab that helped with the test, I think. So that was kind of interesting. So it's not always just families, but that's why it's helpful to reach out to other people in your state and figure out how is this done before.
great. And the theme I'm kind of hearing on everyone's response is, again, state by state. You know, every state has its own unique kind of dynamic. And so know your state, know the players in your own state. And I think that it's also something I'm hearing too, that's so important for our community is, you know, the SMA community has had an effective treatment now for a while and has been on the RUSP for a while, and yet still we see it as a victory that it's 30 states, but that's not 50 states, right? So back to Dr. Adang's point, this, you know, this marathon, not a sprint that you know, as a community being ready for sort of a long haul. We're running toward the end of our moderated time, but I wanted to kind of throw out one more question in relation to newborn screening. And it's kind of for everyone. I won't pick on anyone in particular. So we know that lobbying is a really long and arduous process, and you know, it can be intimidating, and it feels like sometimes lobbying efforts can be more suited to one personality than another, potentially. Those of us who are, you know, a little more willing to put ourselves out there. What are some ways that advocates who maybe don't feel as comfortable jumping into the lobbying process could contribute to progress on, you know, in newborn screening, or just in general in this world of furthering progress for leukodystrophies? What are some ways advocates can get involved versus like getting on TV and, you know, chasing down the newborn screening panel, Lesa? What are some other thoughts to close out?
Well, one thing that I can think of is, so for advocates that aren't necessarily interested in being as public facing or like going through the long, arduous process of lobbying, kind of just speaking to what we've been saying about prepping behind the scenes and becoming as knowledgeable as possible about the disease, about the data behind the disease. And also, I mean, and this can mean not just looking at what is the frequency of the disease in the population, what does it look like, what treatments are available, but maybe even looking at the economics of it, like, so because sometimes that can be an argument that people can make to states that it might be more cost efficient to newborn screen than treat individuals that later go on to exhibit symptoms. But then also, this is for more experienced advocates, but share what you've learned. And we recently have started to map out people in the LDNBS network. It's still very new, so we're working on collecting responses and seeing where everybody's located, but sharing what you've learned and helping others in the process, like that's just absolutely the biggest thing that I think, and that's the purpose of the LDNBS Action Network, is to paraphrase a phrase that Maria likes to use a lot, we're trying not to reinvent the wheel. And so just sharing what you've learned, and then that will help new advocates learn from that as well.
I'd like to offer a broad response to the question, Erica. I think not everybody's cut out to be a public face or to advocate. Everyone has their styles and their temperaments and their interests and their sets of skills. And within our SMA community, what I've seen over a long period of time is the group supporting each other by everybody being offered opportunities to help. So we all help in very different ways. And there are many parents who are active advocates and are very effective at that. And there are other families who choose to help in other ways. And we have a family that their business makes signs. So at the national conference, all the signs are donated by that family. And at that conference, I'm not the kind of guy that goes public and advocates. It's not my temperament. I'm in the room with all the kids who are affected by SMA, providing a support group for them while their parents are in the next room doing the workshop on how to advocate for newborn screening. So I could go down a list of sets of skills and ways people contribute, but the way I look at it is we're all helping in the ways we know how to help, and there sure needs to be enough people. I'm so grateful for the families who do have the motivation and the comfort level and the set of skills to advocate in the ways that Lesa does, and so many other parents I know do. But we all help each other by contributing what we can in the ways we can, in the ways that we're comfortable. And if we all work with our strengths, and then we're going to get the most out of our collective efforts as a community.
I feel like maybe Dr. Al just said it all to that question. I'll tell you the one quote that for me, when I got started in this space, that kind of is appropriate to what you just said. It's an Arthur Ashe quote, and he said, "Start where you are, use what you have, do what you can." And I find that to be such a useful quote when I think about advocating and I think about working in this space. So with that, I'm going to move into the audience questions in the Q&A for our panelists. It looks like we've got a few here. And I just want to, before I start reading these questions, thank each and every one of you that are joining today, taking time out of your day to come and listen and support the community and really find out how you can improve care for the MLD community, and thanks for all the collaboration. Okay, so the first question we have here is, what is the LDNBS philosophy on RUSP alignment? Somebody want to grab that one? Looks like Lesa.
So, as we all have experienced, science often moves faster than bureaucracy. In fact, most of the time it moves faster. And so we don't believe that we should wait, because sometimes RUSP approval takes years. And in the meantime, these kids are needlessly suffering and dying. I know from my own experience, if my daughter had been born just 2 to 3 hours north, she would have been screened and our story would be very different. And so, because we've all seen the power of treatment for those who have been able to have it, I think that if the science is ready and there are clinical trials, or, you know, once there is approved treatment, that if states are willing to add it, that we should advocate for that. Yeah, because like I said, science moves faster than bureaucracy, so we don't really want to wait on the federal government.
And well, also, yeah, so just to note too, the science that we're sort of looking at here too is the Screen Plus data that'll come in with it. They just started their screening program and they're going to build it up right now. It'll eventually be over 8 New York hospitals, and it's being built up incrementally. So we don't know when we'll see a positive diagnosis of MLD specifically, but specifically looking at that data will be really informative for our next steps in terms of looking at what states we want to screen next, and also looking forward to RUSP in the future.
Great. We feel like that question, everybody got a chance to answer. Let me move on to this next one. And I'm really glad this one is coming in, because it was something I was wondering too. And I think it's directed at Dr. Adang.
Yeah.
You were already smiling. I feel like you knew I was going to ask.
I know, it's from my old friend, Dean Sewer. He's not throwing me a softball on that one. He wants to know what my thoughts on stem cell transplant are for newborns. I think it's really complicated. I think the data for bone marrow transplant has been quite variable in the MLD population. Some studies have shown it's effective and others have not been as successful. And I think we need to parse it together as a group and figure out, well, was it less successful in juveniles because it was begun post-symptomatically? Is that why some studies have been less successful? Would it benefit people? I think it also becomes really important in that we don't know how long a bone marrow transplant is protective for, right? And so would you transplant someone, you know, within the first couple months of life if they weren't going to have disease for 30 years? And that's where I think really pulling together both the natural history information as well as transplanters guidance and really coming up with consensus guidelines is essential, because I think it's a really important question that I don't think that there is clear clinical consensus right now. And so it's something I think about every day. And I think a lot of us need to come together and come up with the answer that we think is the right one there, because I don't think what's in the literature now is incredibly clear about who should receive a transplant and who should not.
Great. And then I'm gonna keep asking you a question, Dr. Adang. You might just keep your microphone on the whole time. Just kidding. So the next one is, this one is very interesting to me. You mentioned I think it was you that mentioned some targeting teaching to subgroups. And I think you did it in terms of, you know, kind of watching for those signs and symptoms. The question is, would this include psychiatrists? Who would you include? Who did you have in mind?
Yes, I think that's an amazing idea. I think our adult leukodystrophies oftentimes get underrepresented on these kind of panels. And that's something for you, Dr. Al, going forward. Anywhere between 10 and 20% of leukodystrophies, most of them like have a large subset of adult patients, and they oftentimes aren't seen by the child neurologist. They're very, very late to diagnosis, and they are oftentimes under managed and guided because it's just not something we're as used to dealing with. So I would love the idea of collaborating with like psychiatric associations, psychology associations. What are the warning signs to look at when it isn't just, you know, psychosis or depression, right? Like, and I think from the natural history work, there probably are subtle signs that we can pick up on to better triage. This person needs a test for sulfatides, and this one is okay to just treat as a late onset bipolar break or things like that. In my mind, my list grows every time I read a new chart, and I'm like, well, that's a subtle symptom. Maybe we should start collecting it. But I think orthopedics, I think general pediatricians, I think anyone with developmental delay, I even think child neurologists, ophthalmologists, psychiatrists, psychologists, right? I think that there are many subtle early symptoms that we could be picking up better. And even once a child is diagnosed, I think continuing education in these subspecialties to make sure these subspecialties feel comfortable caring for our children and adults affected by rare diseases, because I think making sure local teams are comfortable at offering the best possible care is a really important part of the advocacy world too.
Great. That was a great response. Dr. Al, did you have anything you wanted to add to that, or?
Yes, no, thank you, Dr. Adang. I wholeheartedly agree. Yeah, what I'd like to add regarding this question, I think the next one, which is related, is that when you have a rare disease like MLD, there are a very small group of clinicians who take an interest in it, as Dr. Adang has. And in my experience as a member of the medical advisory board with Cure SMA, 15 years ago, we sat in a room with that small group of clinicians who took an interest in SMA. And over the years, what's evolved has been an effort to move from that room to train other clinicians about SMA rather than to do the work ourselves. And so what that has taken form with a number of educational programs for clinicians as well as for families, but especially for clinicians, and continuing medical education programming and different opportunities for the clinicians who know a lot about the condition to teach others about the condition. And as Dr. Adang said, what are the signs and the symptoms of MLD? There are a number of video programs and CMEs and different educational tools that have been used to broaden the base of clinicians who are aware of what SMA is, much less what it looks like. So you have to start somewhere. You start small, and at our national conference, we now have a clinical care program where clinicians are invited, and many come and have this kind of programming in order to learn what SMA is and to learn what it looks like. And a lot of this programming is happening virtually now. It's hard to do because it's a rare disease, and doctors see a whole lot of different medical conditions, this being one of them, and this being an unusual condition. So it takes time, it takes effort, but it has paid off in our SMA community to broaden those educational opportunities for clinicians in many, many disciplines. And certainly psychiatry and psychology, in the case of MLD, would be very appropriate.
Yeah, and I just wanted to bring up, I think a really important point is healthcare disparity around the world, but also within the United States, and making sure that regardless of where you live, we support local providers with the right information and how to help. That it shouldn't be that you go to one or two small sites or big sites rather in a country. It really needs to be a partnership and a network covering the entire United States as a first step, but also the world. And I think that's a really important part of it.
That's great. That's great feedback, and hopefully with more telehealth being utilized and some of the technological advances, let's hope that there's a landscape out there that will help us do a better job with connecting the professionals who need to know. I agree. I think that's just such a gaping need in the rare disease space in general. So I'm going to jump to this great question. Is there an opportunity to collect samples on patients with MLD or other disorders before intervening to help further develop natural history studies with biomarkers? This could be dried blood spots collected with newborn screening, but could go beyond that as well.
I'd be happy to take that. So that's from Dr. Paul Orchard. Yes, let's talk. I think there are many potential platforms for this within the GLIA CTM. We certainly have the infrastructure to do that. But I think as we come up with clinical consensus guidelines, we should weave in research consensus guidelines and how we want to best move this forward. As we've all learned from ALD and SMA newborn screening and all the newborn screening, we have a finite amount of information going into the newborn screening process, but we actually learn quite a lot as clinicians and researchers from the families that are unexpectedly identified. And so I think it's essential to weave in research and moving the field forward from the very beginning and plan on it will be a collaborative endeavor for us to learn as much as we can so ultimately we can deliver the best care.
Great. And now I have a statement I'm going to read from Amy Givligio, and she is incredibly knowledgeable about the newborn screening space. So I'd love to kind of read out her advice. So advocates should absolutely reach out to their NBS program and advisories committees first. It's a great way to establish that relationship and learn where each other are coming from. No one wants to be blindsided, and nearly all programs prefer this path than having advocates going straight to legislation, especially because legislation is often unfunded. Great comment on how we advocates can inadvertently create some tension in the space if we don't move wisely and cautiously. And that's just a great point to make, that you know, making sure that we're reaching out to people.
Also, I would like to add, thank you, Amy. Also, Amy will be speaking in session 2, which is next Friday, everyone. So if you haven't registered, you still can. Registration will be open until the day of the event. And if you have registered, then we'll see you there.
Great. Okay, so the next question here is from Dr. Bressan, I think is how you pronounce it. So we have several patients in Brazil who do not fill the requirements for any kind of trial or treatment. Is there anything new for these patients or something that we can do for these families?
Yeah, I'd be happy to take that one. I think, unfortunately, that's a huge unmet need. And someday we'll be able to identify all families by newborn screen, but that's quite a ways off. And so I would love to partner together as we can kind of come up with ways to both better medically manage and potentially offer research opportunities to these families. But I agree that's a gap in what's currently offered. To let you know though, this landscape, it's changing quite rapidly. So I check clinicaltrial.gov, which is the US registry of all ongoing enrolling sites, before I see every child with a rare disease, because I never want to walk in and not have the most up-to-date information. I oftentimes will Google it in case oftentimes the advocacy groups have their finger on the pulse and will post around the time that it becomes more official website. So I think it's just really important to stay active as a clinician. Even as someone that's entirely in the rare disease space, making sure that I'm offering what's up to date with my families, because it does change minute to minute. And it's hard to keep up with. I think that gets to a lot of like having a centralized information source for families and clinicians is a really important thing. It is hard as a general neurologist or a more generalist to keep up with all, thousands and thousands of rare diseases. And so making sure that you have a resource where you can go to that's accurate is important.
Great. If everybody feels like that question was answered, I'll go to the next one. And this next one we kind of touched on a little bit, but maybe people have further thoughts on this. This is from Pam Bennett. Do you have any advice on how to include general clinicians in the education of MLD? And I know we kind of talked about this, but anybody have any thoughts on those primary care physicians, how to include them in the education?
I think it's a really critical part. I think reaching out to things like the AAP and the more pediatric associations, as well as the adult versions, who will be seeing these children. Kids see their regular doctor regularly, right? And so I think they're a really nice resource for us to be able to work together. I think funding testing, right? From the drug company standpoint, that if a pediatrician has concerns about development, I think that that's an area for growth. And then as part of the GLIA CTN, we've put out several webinars that are free for viewing that are clinician geared. And so you can certainly refer to that website as well. And those are available for free, but also for CME if people are looking for clinician CME credit.
Great. And then we have a comment from Bob Rauner, the ULF Foundation. Thanks for joining us. He says, speaking from experience, Amy is absolutely correct. He started going to state MBS advisory committees and attended them for 3 years, advocating for XALD, MPS 1, and SMA. You can end up with a volunteer job on your state committee as a reward for your work. So patient voices are very great to have on these committees. So again, speaking to that really high priority on collaboration and collaborating with state agencies is such a good point. Does anyone want to comment on that further?
I would just say that, yeah, as my experience has proven, it is definitely best to go. So I'm also happy to hear others agree with me, because I also, with other conditions that were brought before the committee, I also saw the doctors feel kind of like, why are we even here if the legislators who don't know anything about science are going to just tell us what to do? So it also did kind of hurt their feelings in a way, because they're there for a reason. They volunteer to be on these committees. At least here it's not paid. And so I definitely think it's important to respect their expertise and do it the way that it should be done.
Great insight into that. I also, I apologize, there was one follow-up comment that Mary Osamine made concerning the real dilemma of adult onset MLD and leukodystrophies being misunderstood. And I think she just made some really good comments. And so I wanted to read this out. The majority of adult onset presents with psychological disorders and are misdiagnosed with other mental health conditions. It can go on for years, and possible treatments like BNT aren't effective. And she just made this great question that we talked about. How do we get the mental health providers to look for a physical cause of these symptoms? Most of them don't look beyond the psychological causes. And I know we talked a little bit about some of that and touched on it, but I wanted to make sure that I read that out loud. And if anyone has wants to expound on that a little, open it up to the panel.
Yeah, Mary, I think that's a very good point, and I agree with it completely. I would suspect one thing that would be helpful would be for a psychiatric institute or someone that sees inpatients or has a practice to do a more broad-based testing across their entire population to see the incidence of what they're missing as evidence that we are missing the diagnosis, because I'm certain we are. I think a paper like that would be really helpful to the field. I think back to an older French paper, which is fascinating to me, where they looked at atypical MS cases across multiple sclerosis centers in Europe, and they found not a small percentage of adults actually had either lysosomal storage diseases or CADASIL or various other genetic disorders, and they had been labeled atypical MS. And so I think that we are very forward thinking in pediatrics, where genetics actually is one of the first things we think about with many of these things. But in the adult world, I think it would be really helpful to build some of the scientific evidence that we are missing many cases, because I agree with you. I think we are, and I don't think MLD is the only thing in the adult psychiatric population we're missing.
Great. Well, this can go on the record for panels that I usually moderate, that we are well within our time. So nice job with everyone staying on track. And if anyone wants to put another question, we have about 5 to 10 more minutes that we can respond to questions if anybody wants to put something in the Q&A. But thank you all so much for joining us, and we hope that you found this helpful. Please remember that Friday, March 5th, we're going to do a session 2. And as you can see, we're going to drill down even a little bit more on the newborn screening, talk about some of the specific efforts that are going on in New York, RUSP at the national level, and then next steps for newborn screening to continue to move the community forward and move progress forward. So thank you all so much for your time. You can always reach out to Cure MLD with any questions or comments. And again, this is recorded. So feel free to reach out and request the recording if you would like to see that, or if you know anyone who wants to view this. And I'm going to read, Pam Bennett made one follow-up comment, and I'd love to read that out. So along the lines of advocacy, how would you suggest going about getting psychiatric institutions to test for adult MLD? She's not going to let you off the hook, Laura.
Well, as a pediatric neurologist, I think you're pushing my comfort zone a little bit. I honestly think that if we could find funding for a project that would do more broad-based testing more universally in that population, that was the way the MS study was done. They did biochemical testing as first tier, and then second tier was genetic testing. I think if we could get funding for something like that, that would be a first step. I think we need to know what the incidence is. I don't know. I'd be happy to partner with someone and advise.
Sounds like a very exciting research project. So I think with that, we are getting close to our time. And again, just I want to thank everyone so much. This was so exciting. It was a long time in planning. I want to thank Cure MLD for all the hard work that went into organizing this and planning it. And thank you all. And I would be remiss if I didn't remind everyone that Sunday is Rare Disease Day. So, you know, make sure you do something to raise awareness for our community, and we will see all of you again, hopefully on March 5th.